And we move on to Dr. NAREN SHETTY. He is from NAREN SHETTY, a very prolific young surgeon, very daring, dashing surgeon. And let's hear him talk.
Fantastic. All right. Good morning, everyone. I'd like to thank Dr. Minu and AIOS for giving me this opportunity. See, in terms of zonular dialysis, there are different kinds and the different causes why it actually occurs. But the key here is recognizing this early. First is in your OPD itself, you have to realize that there is something wrong, and you can also grade it according to what you see here. Now, let's say if you have a scenario where you're missed preoperatively, while you're operating itself, you have to pick up certain signs. Let's say if you're trying to dip your sister tone tip, more than cutting it, there's a depression, then there's a sign that, okay, you have to watch and see, mostly the zonules are weak. Or if while you're doing your X's, you can see the whole, the complex moving, then you have to stop and watch. And even this intraocular zonular dehiscence, you can actually grade it according to the picture here. So now how do we initiate the Rexis? One of the point is you have to start away from the Rexis, away from the zonular weakness, and do not overinflate the bag, because if you because our tendency is, no, this is a zonular dialysis, I have to have a good taut capsule, I'll overinflate it. No, if you overinflate it, you'll break the zonules, so just inflate it the right amount. And then just be aware whenever you're trying to stain, if at all, if the glow is good, just better to go ahead with it. But if it's not good, if you're planning to stain, if you just stain just like that under when there's saline or without putting viscoelastic, what happens? The stain goes into the vitreous. Then overall your surgery becomes really difficult. So a small tip is where you put visco and then you can paint the capsule. So that is a more controlled way of painting or staining the capsule. The next thing is initiating and progressing with the Rexis. So like I mentioned earlier, you start or make your first incision away from your weakness. Once you create a flap, pull it towards the weakness, okay? Pull it towards the weakness. And then what you can do is you can use a bimanual technique where initially while you're pulling the flap, you can either use your dialer to do your initial opening, and then as you keep doing, and you've finished part at least 2 or 3 clockers, what you can do is you can insert a capsular hook. As you can see, I've implanted one hook, and like that you can continue in different quadrants so that there's less iatrogenic breaks because of your Rexis creation. So in case of Rexis runoff, I won't talk about it because previously all the speakers have beautifully covered it. Even the femto lasers also, is Dr. Minu has beautifully covered it. So coming to capsular stabilizing devices, there are many, and most commonly used is the capsular hooks. See, there's also a capsule hook which you have a looped end, which I personally haven't used. I've taken this video online just to show the loop. This is also one of the capsule hooks we can use. But otherwise, regular capsular hooks does fantastic. You don't need to worry. Now, the other use for this capsular hooks is you can also use it to dilate your pupil. Okay, but always remember, whenever you're using these hooks, don't overstretch it, because when you overstretch it, sometimes you tear the capsule or sometimes you damage the iris. So you can see, because I've not overstretched it, still the pupil is nice and round at the end of the case. Now, you can also use capsular tension rings. There are standard ones and the modified ones. When you look at the standard ones, basically it's used when there is generalized or diffuse mild to moderate zonular weakness, and also if the focal zonular weakness is less than 3 to 4 clockers. It's better to avoid implanting these CTRs in cases if there's a tear in the anterior posterior capsule, because in those situations, if you tear, there's a chance of the CTR falling into the vitreous. And try to avoid if there's more than 4 clockers and very severe generalized zonular weakness too. There are different sizes. You can implant it as shown in this slide. Now, the timing is very, very, very crucial. So there's no fixed time to implant, but generally we say as late as possible, and depending on how comfortable you are, at whatever point you're feeling very uncomfortable, just implant it. Whenever, if at all you want to implant it when you're doing your nuclear, when you're doing your quadrant removal, let's say if you removed one of your quadrants, when you see one clear area, then what you can do is position the clear area in such a way that then you can push the CTR into that particular area so that it doesn't hold the cortical matter, so that it doesn't damage when you're pulling out the cortical matter when you're doing your IA. There are a lot of studies showing the CTR does help very significantly in these cases. Now, if you're in a scenario where you've finished your cortical removal and you're implanting the CTR, this is also a way of implanting under irrigation. But whenever you implant CTR, no matter what situation, always use a microexcess forceps, hold the trailing part, and then implant it into the bag. This is the easiest way to implant the CTR into the bag. Or you can also use a preloaded CTR also. That also works pretty good. Now, when we come to modified CTRs, basically they have these eyelets. They are used in advanced zonular weakness. If the clock hour is more than 4 hours, 4 clock hours, and there's a progressive zonular weakness, it's a good idea to use these. So there are different types depending on the number of eyelets that it has. And you can also use capsular tension segments. It gives you a good support of 90 degrees. And basically, whenever you use these devices, you need to use suture to stabilize it and anchor it to the sclera. Normally, all of us, we've been doing where we put the suture into the eyelet when it is inside the chamber. I say it's a little more challenging. It's better to start outside itself, tie the knot in the eyelet, and then you start your surgery. It makes life much more easier. Even more easier is doing the Yamane technique. Basically, what you do is, I think the video is not playing, but anyway, so basically what you do is, you just take a 5-prolin and with a 26 gauge needle from the other side, you flange it first at the eyelet and then externalize it from the sclera, and then you flange it there and you position it. It becomes so much more easier. There are other capsular, stabilizing devices, but I can't go through everyone. So this is basically the surgical planning for these kind of zonular dialysis generally. But what if you have a scenario like this where you have a very, very thick fibrotic capsule? You can see the whole lens complex moving as I'm doing the rhexis with great difficulty. Somehow I finished the rhexis, even though it's small, but I'm happy. And I thought, okay, my job's done, and I tried to do hydro. Absolutely, there's no space between that capsule and that fibrotic material. So what I do is I take the phaco probe with the low vacuum and flow with high power. I just do a punch, and then it creates a punch through the capsule. This is the best way to create it. Do not overforce these capsules because you'll break the zonules. I don't know if you can appreciate here. Let me just play it again. So basically, once I created the punch, the whole posterior capsule came in front because it's very, very weak. So what I did is I went to the hole, put viscoelastic. You can see the posterior capsule going back to its position. It's very, very important to do this. Then I take the cutter and extend the rhexis. In these very thick fibrotic capsules, even though the rhexis is done with the cutter, it behaves like a normal CCC. You can even put capsule hooks to this, and still there won't be any kind of extension or tear. So I go ahead with the nucleus management, and then what I do is, while I'm removing the last piece, I do not finish it. What I bring it to the anterior chamber, put the lens into the bag so that it protects the posterior capsule, and then I go ahead with the nucleus management. And then you can always extend this rhexis with the cutter again so that it's large enough. And this is how the patient looks like on post-op day 1, and the patient's doing pretty good. So I was told to talk about optic capture too. There are different ways of doing it. One is the conventional, and then we have reverse. Conventional is nothing but where the haptics is more anterior and the optics is more posterior. And in the conventional, there are different kinds where you have anterior, only the anterior capsule, posterior is posterior capsule. Then we have both, and so on and so forth. And these are the images how actually the position of the IOL is different. But all of us normally do one simple thing, is the anterior conventional optic capture. So let's say you have a scenario like this where you have a PCR and you have few pieces in the chamber. This is pretty common. So what you do is put viscoelastic, push the pieces to the angle, and then after you push the pieces to the angle, you place a 3-piece IOL in the sulcus Once you've placed a 3-piece IOL in the sulcus, it creates a scaffolding so those pieces don't fall into the posterior segment. Then you continue with your phaco very comfortably without having the fear that it's going to fall. And once you have done that, you can do your optic capture. Whenever you do your optic capture the optic perpendicular, the haptic optic junction. First, you tuck in one side, so you can see it's come, the anterior capsule has come to this edge. Then you start pushing the other side downwards. Then automatically the anterior capsule gets caught there also. So you have an oval shape. That means you have captured it well. So at the end, I want to just say that in these kind of scenarios, it's very important to prepare yourself. Think of a clear idea on how you're going to move forward with these cases. So that way you have opportunity to improvise. Thank you for your time.